Welcome, podcast pediatricians. And it's been a long time, Matt, like 3 months. And It's weird that the longer we go between episodes, the more people download them, almost like they're telling us that we would do better if we just stopped doing episodes. What do you think?
Well, you're right. It's taken us a long while to get back on the mic here, hasn't it? I've been trying to avoid you as best I can over the last 3 or 4 months, but you finally tracked me down, Changed my phone number and everything.
But yes, we are back, and we are the podcast pediatricians from high atop Caesar Rodney Square in beautiful downtown Wilmington, Delaware. Look at the people down there, Matt.
Hey,
it's a hot day
they
here.
They look like ants.
And Matt's on call. I'm not. I'm Rob Walter.
And I'm Matt Gotthold. As always, you can download this podcast on iTunes, Stitcher, and Google Play. And please check out podcastpediatricians.com to see interesting pictures, post comments, and suggestions.
Yeah, give us some suggestions for what you want to hear.
We're happy to talk about pretty much anything.
Anything.
Yeah. And if we don't know about it, we make it up.
Yep.
Which is even better. Yeah. So, and please, if you think about it, check us out on iTunes and leave a review. Of course, we always like constructive criticism, but we also like 5 stars. So do us a favor and think about doing that. We were contacted by Spotify to join them, but every time we tried to give them our RSS feed, which is what you need to kind of tap into these systems, it keeps coming back error in description. We've called them multiple times, and they were very nice, but unhelpful. Rob even met somebody who worked for Spotify who said he would take care of it, but never did. So Spotify is dead to us.
Dead. Dead.
Or rather, we seem to be dead to them. They could beg us, and we would never associate ourselves with them unless they asked us nicely.
Really nicely.
Anyway, so our disclaimer. We are sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community's standards of care.
And briefly, remember our sponsors, Triage for Pediatrics and Julie Ortiz, who will take care of your overnight calls for any pediatric caregivers. You can call her at 214-450-5030 or email her at jortiz@triage4, that's the number 4, pediatrics.com. We love it, and Matt's on call today. He's been on call weekend, but he's gotten sleep because she takes care of everything overnight.
Thank you, Julie.
Thank you. And then also Campus Quilts at campusquilts.com. Again, you can take your old T-shirts and make them into a quilt. Christmas is just around the corner after Thanksgiving.
Christmas
and Hanukkah,
is always around the corner.
And Hanukkah. They're great. So campusquilts.com, mention Podcast Pediatricians, get a nice discount. So, Matteroni, how has your summer been?
Matteroni better than Matteroni. Good summer, actually. This is the first time that I felt like the summer kind of was just at the right pace, just the pace that you would want it. All my kids are older now. My youngest is 20, and it seems like there's not such a rush to the summer anymore. So it's kind of passed in a nice leisurely. I've really enjoyed it. It's been a great summer. Yeah.
Nice.
How about you?
Good. Had my daughter's law school graduation. At the start, she went to the dark side, yes.
Somebody to bail us out after this. Nice.
But she's going to practice law for the common good. And I went to Italy with my friend Susan, and I used some of your guidebooks from your trip last year.
Excellent.
It was so good. Mm-hmm. And in fact, Matt,
you didn't fold the pages, did you?
Here is your present.
Ooh, wait a minute. Ooh, you didn't show this to me.
I didn't show it to you.
Wrapping sound.
I want our listeners to hear your glee.
Such a beautiful bow.
It's just a bag.
It's just what I wanted.
I know.
Yeah. I will say that throughout the course of my life, I've never been able to find a decent belt. Then again, I've never paid more than $10 for one either.
See, you walk around Florence, and you can't help but run into a million places to sell belts.
People who have fabulous leather goods. So I did ask Rob to if he would think about picking me up a belt while he was over in Italy, and
I scoffed and said, "No way." Of course, I did. Ooh.
Ah, there you go. Sound. That's a beautiful one. Thanks, man. All right.
You are welcome.
Let me know what I owe you. As long as it's $10.
Okay. More than $10. All right. Back to Italy. Just got to mention the marble statues of Bernini, the Primavera by Botticelli, and 40 minutes sitting on a side bench staring at the Sistine Chapel ceiling with the help of a Rick Steves podcast. And the beauty of Cinque Terre and having an Aperol Spritz every night.
I never had an Aperol.
Oh,
tell me
Aperol.
about it. Does it come with an umbrella?
No.
Yours did.
You could.
You like umbrella drinks.
Equal parts Aperol and Prosecco, and you put it over ice, and then you add just a dabble of club soda, and you put a sprig of orange in it, and it's the drink of the summer. Everywhere we went, people are having an Aperol Spritz, and it's really good.
What's the base of an Aperol? I mean, like
I knew you'd ask me this. I don't know.
Yeah, you were looking at me with like fear in your eyes.
The bottle says Aperol. Maybe it comes from the Aperol tree.
We'll
Maybe
have to look that up. We'll get back to you, faithful listeners.
I'm not going to get
that
back
one.
to you. I don't
because
care.
Frangelico is what, like hazelnut, right?
I don't know.
And wait a minute, Sambuco is, I think, isn't it licorice, or is that ouzo? I don't know. I just take shots of whatever's around.
I don't know. But back to that Sistine Chapel. So you remember how from last year when you saw it, all the naughty bits of the nudes in Michelangelo's Last Judgment were painted over, actually by the artist Daniele de Volterra, years later because the popes didn't like the nudity.
Yes.
Remember that story?
Yes.
So that's outrageous, right? Well, here in Delaware, the Air National Guard is considering covering the bare buttocks of Adam and Eve figures in a giant mural painted by Jamie Wyeth 50 years ago when he served in the Air National Guard during the Vietnam era. If the Delaware Air Guard cannot handle the bare bottoms in an historically important Jamie Wyeth early work, then I think they should just donate it to a museum who can, so we can appreciate it, not paint over it.
This is Jamie Wyeth, for God's
Jamie
sakes.
Wyeth.
The son of Andrew, the grandson of
NC
N.C. Wyeth.
Which is a great exhibit now at the...
yes, at the Brandywine. Yeah.
The Brandywine River Museum.
Yeah.
Yep.
So, I mean, come on. This guy is like an American icon, and you're going to paint over Adam and Eve's bottoms, because it's ridiculous.
It's ridiculous.
Anyway,
Italy was great, and then Matt and I both went to the happiest place on earth, Hot Topics Pediatrics in Disney World, a few weeks ago.
So, I will admit to the fact that it was an excellent conference, and it always is. And with all due respect, I know I tease him a lot, but Rob does just the most outstanding job as the main moderator at that conference.
Thank you.
Really fantastic, and really, it's a pleasure to go. It's a very practical-minded conference, and I just learned so much going there. This year, I had the opportunity to take my son, and we had a great time. Although I will say, only once did I step inside the parks. And it was only to eat. My son is as big a fan of Disney as I am, which is not. But we did have some great adventures. We played golf. I played for the first time in 30 years. Mercifully, we only got 2 holes into it because we got pulled off for thunder and lightning. We went to see Blue Man Group, which I had seen before, but my son never had. But the highlight was we went indoor skydiving, and it rocked. First I was like, really? $60 for 45 seconds? Like, that doesn't sound like a very good yield, very good return on investment, right? But it was amazing. Oh my goodness. I mean, amazing to the extent where I actually looked into like, okay, what does a franchise cost? I'd love to spread this good cheer all over the place. And since I'm about $3.999 million short of the goal, because it's a $4 million project, I backed off a little bit.
But it may be a way for you to get some patients in your office, since you could use whatever
for you, what you do is you would turn on the fan and then real quick turn it off, and then you'd be able to see some patients. maybe for a sprained ankle or something.
So in contrast to you and your son not liking the park, I went this year with my sister, and the last time we went to Disney World together was 1974 when we stayed at the Polynesian, and she loves it. I love it. So did
your mom make you hold hands again?
We called her.
Don't let Bobby get lost.
We went on the Haunted Mansion, my favorite ride, and just the classics Disney World. Then we went to Hollywood Studios. Now, Star Wars doesn't open until August 29th, but we went to Toy Story Land, which we loved. And my favorite ride this year was the Slinky Dog roller coaster there, where when you get to the tippy top, you can look over and see the Galaxy Edge Star Wars ride with a big Millennium Falcon, which got me very excited.
Made your heart all aflutter, right?
I need to go back next year. Did not have the turkey leg this year, but we ate well. So, okay.
You'll live a couple more years because of that.
Okay, Maddie Myrtle. Who wrote that? Okay, Maddie Myrtle.
I don't know.
You know I like to keep a pile of things to talk about. It's getting really high after multiple months, so we're going to tackle some of them now. And then we'll talk some dermatology and asthma pearls that we took away from the Disney meeting, and maybe go over a couple papers I presented as most interesting of 2019.
Yeah, but we would be remiss if we did not mention that we're taping this not long after the massacres in El Paso, Texas, and Dayton, Ohio. Just more of a string of gun-related massacres in our country. Not to get too political here, but please, can we please put some limits on these assault weapons and ammunition magazines and get universal background checks and pass more red flag laws that get guns out of the hands of people who have mental illnesses? Like, please.
Really?
Okay.
It's I
Let's start.
What do you keep saying? We keep saying the same. Keep saying the same thing
like
over
you're
and over
banging
and
your
over
head
again.
against the wall, and then suddenly 16 more people are dead. It's anyway. So let's start with sunscreens on a brighter note. You like that? Of course, everyone listened to our episode on sunscreens, which was Podcast Pediatricians number 29. Also known as Sun,
and the Frankenberry stool.
Yeah. In which we make recommendations amidst our usual hijinks about sunscreen.
Wait.
Whoop, what you got over there?
I have your snack. We forgot our snack.
Ooh,
Here,
wait a
Matt.
minute.
Here's our episode snack.
That looks eerily enough like... Is this Frankenberry stuff?
Taste it.
Wait a minute.
Just taste it.
I need to add the audio.
What do you think, Matt?
It's berries.
Do you like it?
I like it now.
Okay, so let me just tell you.
Is that generic Frankenberry? Did you just poison me?
No, it's not, and it's not dog food. But you just ate some puffs that have egg, milk, shrimp, cod, salmon, almonds, hazelnuts, walnuts, peanuts, cashews, wheats, and oats with a strawberry flavor in them.
I feel my throat.
So you get details on this. This is these snacks. It's a Spoon something. It's a company that's brought out these snacks to give to young children. There's these puffs for 6 months and above. There's also powdered form you could put in food for 4 months and above for infants.
Interesting.
To introduce all these proteins early to prevent later allergies, just like we talk about doing with peanut allergies. And we do now. We give it early. But now they're giving everything at one time. And they had some early studies showing that it looked very promising, and this might be great. This may be a way to prevent almost all food allergies, perhaps. The only caveat I have is you give this to the kid, he has a reaction to it.
Yeah.
There's 15 things, and you have no idea which one it is.
How do you backtrack on that?
I know. It's like those days it was resident when I gave you all those antibiotics and you
I
blew
love
up.
that. Yeah.
So
my scars are still here.
On the other hand, we keep an open mind, but they don't taste good,
No,
do they?
no,
Okay.
they weren't
All right.
good.
I'm sorry.
I mean, they were good in like a child
We have a
cereal
snack
kind of
tradition.
fleed.
So stay tuned. Giving these early snacks to young infants with like every single allergen that's high risk may be the future.
I'm sure you've had people in your practice do that, but since we're so local to a children's hospital, it's not been uncommon for folks to decide that they were going to go park themselves at the children's hospital playground and then offer their kids various things to eat to see if they had a reaction, because the emergency room's right there. That's been the logic. And I've always been like, I've had mixed feelings
We had
on
a
that.
speaker and an ER doc saying, that's a
Please
terrible
stop
idea.
doing that. Yeah.
Stop doing that. Please,
Yeah.
we do not endorse that.
But I can imagine, this
whatsoever.
kind of gets filed in the same part of my brain in terms of, okay, we're giving you 15 new proteins.
Okay,
Right?
at least you're in your office, but I know. So I'm not going out of my way.
The jury's out on this one.
I told the detail person I'm not going away to do this right now, but I want to pay attention and see if that truly is going to be something that's going to be a good thing for the future.
Right. As you recall, in the United States, beginning in the 1970s, sunscreens have been regulated by the FDA as over-the-counter medications and has not undergone testing the way modern pharmaceuticals have. In Europe, the regulation has been even more lax, since sunscreens are considered cosmetics in that part of the world. This is why Europeans have many more sunscreens than we have in the United States. There's really just not the same type of regulation. Finally, the FDA started to examine these products more closely and has looked into to what degree these chemicals on the skin are absorbed into the body and what could be the effects.
And I think all of us were a bit stunned by the JAMA study that recently came out looking at the first part of this question: how much of these chemicals are being absorbed? The study was done on 24 healthy people who were given sunscreens, including sprays, lotions, and creams. Each applied the sunscreens 4 times a day over 4 straight days to about 75% of their bodies. That's not that dissimilar to what we do with kids. We say to keep putting it on and put it on all your exposed areas at the beach. And then they measured blood levels of the chemicals in the sunscreens, such as oxybenzone, ecomusal, avobenzone, and octocrylene. The blood levels of each of these chemicals were found to have concentrations of greater than 0.5 nanograms per milliliter of blood after the first day of use, and then the levels increased every day they measured from day 1, day 2, day 3, and 4, just kept getting higher, which indicates there's an accumulation of the chemicals in the body with continued use. Now, 0.5 nanograms per milliliter is the level that the FDA says that anything above it should trigger a toxicology assessment to see if that substance causes cancer, birth defects, or other problems. But let's be crystal clear, there is no evidence that these chemicals are unsafe at all. The fact that these chemicals can be found in detectable levels in the bloodstream of those who use them is not evidence that they are harmful. And we know for certain that unprotected skin exposure to the sun's UV rays can cause deadly melanoma. But for those of us who care for children, especially babies and young children who have large surface areas compared to their total size and are more susceptible to chemicals that are possibly dangerous, it is a bit frightening. And as we mentioned in our sun episode, some of these same chemicals have been found to damage coral reefs. They've actually been banned in Hawaii and in Key West, and even in my favorite country in Micronesia, Palau.
Wow, Palau. Our good friend and colleague, Dr. Aaron Carroll from Indiana University School of Medicine, wrote a nice article in the New York Times last month about all of this and made the point that the physical barrier substances used for sun protection, like zinc oxide and or titanium dioxide, do not generally get absorbed, and there is not a concern about their blood levels. As far as this goes, with this in mind, many of us are suggesting to parents that they consider moving toward these mineral-type sunblocks, like zinc oxide and titanium dioxide. These sun barriers, like zinc oxide and titanium dioxide, will often appear as a white coating on the skin once applied. Think of Queen Victoria, but without the lead base, which these days is not considered aesthetically pleasing. Some newer versions of these products can be rubbed in so that they're not so white on the skin. What do you tell your 3 patients, Rob?
Hey, I'm up to 9 patients now.
Nice.
So, first of all, Dr. Carroll is not our good friend. I'm sure he has never heard of us, and he would not want to be our friend.
Well, maybe he wouldn't want to be your friend.
Maybe. But we do reference his work often, and it's really good. Obviously, kids should use UV blocking shirts and hats, take advantage of shade. And I do mention it's probably safer to use these chemical compounds that get in your blood if that's all that's available to prevent sunscreen, if that's all that's available to prevent sunburns. And I also personally tell parents to avoid the spray-on sunscreens because I worry about them breathing them into their lungs, and I think it's more likely they can miss areas when using spray as opposed to rubbing them in physically. But yes, I am pushing the zinc oxide and titanium dioxide barriers this summer. And you?
Yeah, and I've never been a fan of the spray-ons, even though I know that my kids will use them out of convenience. But they've really been proven, I think, time and time again, not to be as effective.
Okay, next subject. Sometimes you read an article and you say, that's BS, that's ridiculous, and here is the latest one for me.
But before we attack and belittle this article, we need to explain what Apgar scores are for those of our loyal listeners who are not familiar with this term or who need a refresher like Rob did.
Well, and it's true. One of my least favorite things in training was going to the DR. I know a lot of people out there as pediatricians still go to the DR, and God bless you. But that's not my favorite thing. When I say DR, I don't mean the Dominican Republic.
Oh, okay.
Because that could be nice, although it's gotten scary for tourists this last year. You read about those things?
Yeah.
But again, we digress.
Mm-hmm. As usual.
So Apgars.
This technique of evaluating a newborn status was invented by Dr. Virginia Apgar, who was the woman first to become a full professor at Columbia University College of Physicians and Surgeons.
In New York City.
In New York City, we'll give you that. She was an obstetric anesthesiologist and created a standardized method for assessing a newborn's status as the baby transitioned to its new environment outside the womb. So, the Apgar score is based on the assessment of 5 observations, including heart rate, respiratory effort, muscle tone, reflex response, and color. The status of each of these findings is given a number from 0 to 2, and then the points are totaled to become the baby's Apgar score. This means of assessing newborns was first presented in 1952 at a scientific meeting and then published in 1953. Although there was some debate over the value of this, the Apgar gradually became accepted as a standard that's now used worldwide. Eventually, a 1-minute and a 5-minute Apgar score have become the times used to provide a reflection of the infant's well-being at those times after delivery. Essentially, the numbers are a quick shorthand snapshot of how a baby is doing. Conveniently, Dr. Apgar's name lends itself to an acronym for this evaluation.
So, do you think she published it like, I want this to be named after me?
I think she probably changed her name to make
Maybe.
it. She used to be. Wait a minute. What was her name? She used to be Virginia Lowenstein, and she changed it to Apgar for just this reason. All right. So A is for appearance or color. A 0 means that the infant's completely blue or pale, whereas a 1 indicates that only the infant's hands and feet are bluish, and a 2 means that the infant is completely pink. The P in Apgar is for pulse or heart rate. If the infant has no heart rate at all, then the score is 0. If the heart rate is less than 100 beats per minute, it is a 1, and if greater than 100 beats per minute, the score is a 2. The G is for grimace, response, gag, which is a reflex to noxious stimulus. Here a 0 indicates no response to a stimulation, a 1 represents some facial movement to the stimulus, and a 2 means that the infant has a dramatic response to the stimulus, like pulling away or sneezing or coughing or crying with a noxious stimulus. As a side note, I tried this on Rob using car battery cables. I had to convince him I needed to jump. First he pulled away, and then he cried. That would be a 2. I have found that if you wait...
And I wet myself.
That's right. You get extra points for that. I found if you wait a few months between these tests, he falls for it again. Instructional and amusing at the same time.
Okay, wait. So wait. Speaking of cars, yesterday I did something car-related that was the first time in 58 years. I broke a 58-year string of doing this. And it was actually the first of 2 generations. I talked to my dad. He'd never done this before. So what do you think I did with my car?
Washed it?
Nope. Well, yeah, I washed my car.
I've only washed my car twice.
I changed my tire.
By yourself?
By myself. And it was hot.
Did you watch a video on it?
I did. You know, I came out and it was a perfect situation. Saturday morning, I was busy, flat. I didn't have to go to work, which is nice. And I thought, should I call AAA? And I'm like, you should be able to do this.
Man up, Rob.
And I did. And I called my dad afterward. I said, guess what I did? And I thought he'd be all proud of me. He's like, why didn't you call AAA? So you're missing the whole point. The point is that I did it by myself.
That's because you grew up in that plush Long Island environment.
I knew you'd say that. It's a Long Island.
Not like it was in Jersey.
The mean streets of Long Island, yeah. So have you changed a tire lately? Because I got a little flummoxed because I couldn't get all the
lug nuts
off because one of them didn't fit. Because now the newer cars, one of the lug nuts is called a lock nut. The part that goes over it is in your glove compartment, and it's given to you separately, so someone can't just steal your tires.
No,
so I had to call the dealer. I said, I think there's something wrong. There's one that doesn't fit. He goes, well, that's the lock nut. Look in your glove compartment. I was like,
gosh. That's how they get
I'm glad you didn't know that either.
Yeah, no. But I thought you were going to tell me that you called AAA.
I did not call AAA. And then I went to the dealer. I convinced them to try to take it out to patch it. And there was a 6-inch roofing nail in there. I mean, the guy's like, I've never seen a nail. How do you get a 6-inch roofing nail in your tire? Like, how do you put that in?
You can't really kind of a practical joke. No, I don't know if I shared with you. Last year, I used AAA
You told me
times?
About
within
concert?
like 2 months.
Yes.
Yeah. I managed to blow 3 tires within a
I
month.
could have
different tires.
I could have done that, but I was like, I need to learn how to change. I mean, I've showed my kids how to change a tire by like showing them where everything is and talk them, but I've never done it.
Oh, I've changed lots of tires, but when it's a flat, a lot of new cars don't even have the little donut thing that you can put on there anymore.
Right.
So a little bit up a creek.
All right.
But anyway, back to Apgars.
You're proud of me, right, Maddie?
I'm always proud of you, Rob.
Thank you, Maddie.
Yep. So just as a quick recap after our digression. So Apgar, the A is for appearance, the P is for pulse, the G is for grimace or gag, and on to our next letter, which is another A, and this is for activity or muscle tone. Here a 0 represents no movement or floppy, and a 1 is if the baby's arms and legs flex, but with little movement otherwise, and a 2 is earned for active spontaneous movement. And lastly, the R for respiration or breathing rate and effort. In this case, 0 indicates no breathing, 1 is given for slow, shallow, or irregular breathing, or for a weak cry, and 2 is for normal rate and effort and a nice strong cry. So to get the Apgar score, the scores of these subsets are added up with a score of 0, 1, or 2 for each of the 5 categories. The lowest score is, Rob?
A 0.
Nice. Have you been reading?
I have.
And the highest possible score is a 10. In general, we pediatricians have always thought of the total score of 0 to 3 as very low and concerning. A score of 4 to 6 is moderately low, and 7 to 10 is normal and reassuring. Again, we use these scores as a rough gauge of how a baby's doing at a certain time after the delivery. We are careful to tell parents that these scores are not necessarily predictive of how a baby's going to do, either in the short term or in the long run. Certainly, transition from the womb to the cold, bright world, some infants can have some temporary difficulties, but with a low initial Apgar score, this is not unheard of. But we give more weight to the score at 5 minutes, and if the period immediately after birth was especially concerning, we do a 10-minute score. Generally, only the 1 and the 5-minute scores are recorded unless the postnatal period was particularly worrisome.
And we rarely see an Apgar score of 10. Because
there was Nadia Comaneci.
Almost all babies will be a little bit bluish in the hands and feet. That's called acrocyanosis and can persist even when the baby's ready to go home and even in the first couple visits in our office. So with that background, we're ready to go on the offensive. In an article in the British Medical Journal from May of this year, researchers in Sweden looked at over 1.5 million newborns and concluded that Apgar scores of 7, 8, or 9 were associated with significantly higher infection rates, breathing problems, and brain problems than Apgar scores of 10 at 1, 5, and 10 minutes following delivery. So basically, they're saying that only 10s are acceptable. So do you see 10s very much, Matt?
Never.
I feel like if you do see when someone paid off the OB or the midwife to say, hey, give me a 10.
My kids had 10s.
Right. So, and I've never seen one at 1 minute.
No.
And so to me, this observation is just is nuts and useless. In addition, it's dangerous to give parents the worry about their baby's status if their kid's Apgar is less than 10. Now, the Swedes obviously seem to use a somewhat different scoring criteria than we use here, but the scoring is pretty standardized. It was invented here, and I feel like we own it a little bit, so we get to use some of the rules. It just was mind-boggling that they would put that out there, and it made the national news that you need to have a 10 to make sure your child's really going to be healthy.
Yeah. Isn't there some type of international guideline that insists on consistent definitions of like Apgar scores?
I don't know. I think one of the reasons maybe there's not is because no one's ever used the Apgar scores to use it as a predictor.
Right.
It's just a shorthand for us to see how they were doing.
Plus, in the real world, Apgar scores are often determined by whomever seems to be at the delivery and in a position to assign them. If a baby's delivery is complicated or an emergency arises and there's a pediatrician or a neonatologist or a neonatal nurse practitioner present, they'll be the ones to give the Apgar. But if the delivery is routine, it could be the OB or midwife, or it could be one of the nurses present. So I just hated to see a headline that insinuates the need for a perfect 10 Apgar score to reassure pediatric caregivers and parents. Will delivery room personnel feel pressured to give a perfect 10? Perfect 10s are for Bo Derek, man. Did you like that movie, Rob?
Okay, you tell me. I was 18 years old when that came out, so what do you think?
Oh, I was 17.
Okay.
Actually, I might have been 16 and convinced the person at the box office that I really had to see Bo Derek with, in all her glory. The hair was just exotic.
And I don't remember the movie as being particularly good.
Oh, no.
But it didn't really matter.
No, and what was the music that was played? Bolero, I think,
yes,
right?
Yes,
uh-huh.
yes.
Yeah. Which is not something I've listened to since. Yeah.
All right. So next, a little medical nugget of interest is that the FDA just signed off on the first medical device to treat ADHD. It's an external trigeminal nerve stimulator, the Monarch E-TNS, that's available by prescription only. Now, the device is the size of a cell phone with a wire that connects to a patch that is put on the child's forehead overnight while they sleep. It sends a very low electrical pulse through the trigeminal nerve, which is just under the skin on one's face. This then stimulates nerves in the brainstem, which in turn affects multiple areas of the brain. The manufacturer, Monarch, reports that neuroimaging studies show the ETNS increases blood flow to the brain regions that are related to regulating attention, emotion, and behavior. This method is already being used in some areas to address depression and anxiety symptoms. And I know some local neurologists who are using it more and more for depression. Now, in a clinical trial involving 62 kids with ADD, there was significant improvement for those treated by this modality compared to the control group, and that's how they got it approved. The potential side effects reported: drowsiness, increased appetite, difficulty sleeping, headaches, and fatigue. There were no serious side effects. It's approved for ages 7 to 12, and the study results for this product seem to resemble the results of non-stimulant medication treatment. And the device currently costs about $1,000. What do you think? What do you think, Matt?
I need more information. Yeah, I think something like this is fascinating, and the fact that they've been able to prove that it increases the blood flow to certain areas of the brain is good, but that infers that increased blood flow is good. You know,
Right.
I think that's that's a little bit of a presumption.
Right.
Now, again, these people know a lot more than we do, but I would wonder about that.
Right, and they're using it for depression a lot more.
Yes.
As Matt and I say a lot, we're probably going to wait and see how this plays out before we're going to be a pioneer on this, but interesting.
Yeah, it is interesting. And some of you also may have heard that there is a new ADHD med out on the market called Jornay PM. It's a methylphenidate pill. This is the first stimulant medication marketed that's designed to be dosed at night. It's being detailed as a medication that's designated to work as soon as the patient wakes up without the lag in effect during the first part of the day. Do you see this in your patients sometimes, Rob? Like, the parents can't wait to get their medicine into them because they're a mess before that.
I do, but I can't say that I see it that much.
No, I have a
compared to
handful
how
of
they
kids,
keep to push like everybody needs this.
Sure. It's also said to last longer since it's absorbed in the colon for longer, more gradual release. Now, when the company came to my office to tell us about it, I asked about, what if the child has a slow bowel? What if they're constipated? Does this, does this perpetuate the medicine? And I think the woman was a little flummoxed by my question. She said not that they knew of. But I would think if you have something languishing around, and
In your colon.
does it all get used up? I don't know.
And my first question was: so we traditionally give all these stimulants in the morning. What happens if someone mistakenly takes this in the morning? Aren't they going to be up all night? Yeah. And her response was maybe, probably. Now, again, to be fair, you tell people not
like
to, but
the concept's interesting. I don't want to slam the company. I'm sure it will have its place.
Yeah.
But I think there are a couple of questions that we may have about its use.
Yeah, it's tier 3, so you have to fail other things, and
it's
so
methylphenidate. We already know methylphenidate. It's not like
so
it's a
another
brand new
one.
substance.
We're not going to jump to be an early adapter, but interesting. We'll see what happens.
For sure. Okay.
Now, there also was a cool article a couple months ago that showed that in states where the cutoff for kindergarten entry is September 1st, children born in August were significantly more likely to be diagnosed with ADHD than children born in September. And that study was highlighted by Dr. Jess Tomaszewski at the Hot Topics and Disney World meeting. And it really goes to show how the youngest kids in a grade will often be more immature and perhaps have more discipline issues, and then potentially go down the road to being diagnosed as having ADHD. Now, I absolutely can see how this could be the case, and really made me think harder about trying to keep that in mind about these kids who may have borderline ADD. How about you?
Yeah, so this really goes to, I think, a fascinating overall subject, which is how one compares to one's peers and what is considered to be a peer. As Rob mentioned, so this study sounds fascinating, but this study immediately made me think of a Malcolm Gladwell book called Outliers, in which he discusses a couple of different situations wherein people have an advantage of their discipline based on the time of year that they were born. So in a chapter in his 2008 book, Outliers, author Malcolm Gladwell studies the birth dates of successful ice hockey players and discovered that there's a disproportionate number who were born toward the beginning of the calendar year. And his explanation for this phenomenon relates to the age cutoff date for youth hockey leagues. Interesting. The nearly universal cutoff date for hockey leagues is December 31st. Players born shortly after the cutoff date are a few months older and more developed than the average competition and would therefore have a slight advantage. Now, this advantage is more than just a month or so. This is an advantage that builds on itself. Since the slightly older, bigger, and stronger athletes are selected for all-star teams and travel squads, they spend more time honing their skills and benefit from superior coaching and the added attention. Within a few years, a slight advantage has turned into a significant ability gap, not because the players born in January or February were naturally better athletes than the ones born in December, but because they had greater opportunities to develop. Then, Malcolm Gladwell notes that we see evidence of this phenomenon in other areas. The American education system has a relatively arbitrary cutoff date to start kindergarten. Cutoff dates vary from school to school and state to state, but most fall between August 1st and December 31st. But regardless of when the cutoff date falls, Gladwell's theory has validity in terms of education. The oldest children in each grade hold a definite advantage which does not disappear with time. In fact, Gladwell says that children on the younger end of their grade are underrepresented in colleges and universities when compared to the other kids by over 10%. This is fascinating.
It is. You love your Malcolm Gladwell. You want some...
I don't agree with everything he says, but even the points that he makes, and people have argued them, they're at least debatable points. I mean, they're really interesting, I think.
So what's that word you used?
Fascinating.
Yes, Mr. Spock. Fascinating.
I set you up.
Damn it, Matt. I'm a doctor, not a car mechanic.
No.
Did you get that?
No.
Star Trek? Damn it, Jim.
Oh, I got
I'm
that.
A doctor,
I didn't get the car mechanic thing. Is that from some spoof?
I love to throw some TV that you don't know. Okay, we are going to be right back. Okay, boys and girls, we're back, and we're going to highlight topics from the excellent Hot Topics in Pediatrics in Disney World a few weeks ago, and we'll cover more in the future. But these talks included information that made me think, wow, that could change what I do in the office right away.
So the first two topics are dermatology related, hyperhidrosis and infantile hemangiomas. And these talks were given by Dr. Jim Treat from CHOP, who spoke last year and who is really just amazing. We want to remind our listeners once again that any misinformation in our recollection of the topics as they were presented are our fault and not Dr. Treat's. So Dr. Treat moved to Philadelphia at the age of 2 and did all of his training from college to med school to residency to fellowship in Philadelphia.
And I mentioned that when I introduced him, pointed out that that meeting was only the second time in his entire life that he ever left the city of Philadelphia. The first time was last year when he talked for us. So we were very, very proud of him being a brave boy. Mm-hmm. I did test his Philadelphia cred by asking him, what is the best cheesesteak in Philly? And at the end of his talk, he got the right answer, which was Jim's. Whiz Wit. How about you, Matt?
I'm a Knicks guy. Actually, I'm a pork guy.
Well, I know that, but we're talking about cheesecake. All right, you don't get to vote. And but I think you would agree with me that it's not just the meat; it's rolls, and the flavoring.
The roll has an awful lot to do with it.
And we talked about the meeting, but I have to ask: did you like my Momo mask?
It scared me a little bit.
It was really creepy. Yep.
Anyway, the first topic is primary focal hyperhidrosis, which is excessive sweating from the eccrine glands. This, of course, is different from the smelly apocrine glands that we detailed in our Earwax is Lit episode, which, by the way, I think was the best title.
Gosh.
Rob is brilliant at giving these things titles. If you missed that one, it's chock full of everything you ever wanted to know about earwax. So, hyperhidrosis is excessive sweating of the underarms, the palms, and the soles of the feet, or any combination of these. This can occur in up to 10% of people. Certainly, we want to make sure that there are no other medical conditions as a source for this condition. Things like hyperthyroidism or a rare tumor called a pheochromocytoma. This tumor can also cause high blood pressure and nerve injuries, etc. But there is often a genetic role in most of these kids. You'll oftentimes find that their mom or their dad have a real issue with perspiration as well.
Yes, and it's really, really frustrating for everybody. And I don't know about you, Matt, but I've had so many high school and college kids over the years really distressed by the excess sweating, and I've always felt a bit helpless.
Oh, you feel so badly for them.
Right.
Yeah.
Now, the main treatment we've had, and my first go-to for years and years, has been Drysol. It's a prescription 20% topical aluminum chloride solution applied to the armpits at night 1 or 2 times a week. You can put a little saran wrap under it to increase its effectiveness, and you want to read the directions really carefully. Make sure there's no open cuts. It does sometimes help, but often it does not. A second treatment for hyperhidrosis is an iontophoresis machine. This can be purchased online, and I see that you can go to Amazon and buy it for $299. These machines use a low electrical current through a liquid solution that the patient places their palms or feet in for about 10 minutes at a time. And it sometimes helps, but I've not been particularly impressed. But please, please, if you get this, do not put your head in it if you have ADHD or depression. That's a totally different thing.
And remember, it's if you do put your head in it, eyes up, not down. No, it is a very fascinating subject, the way that I think electricity is used in medicine these days. It's really... It's funny, you go back to, wow, years ago people were getting whatever, shock therapy and this, that, and the other, which is still a thing. But the fact that now we're able to utilize some of these things just in a very toned down version for some really troublesome issues is fascinating. Then there's glycopyrrolate, which is also known as Robenol. And I think we both remember that this medication is used to decrease salivary output in children with increased amounts of saliva. This seems to occur most often in kids with cerebral palsy or with severe developmental delays. The med can be used off-label for excessive sweating. The main side effects are anticholinergic in nature, and one has to be careful with athletes who have their capacity to perspire changed, which can be a serious threat to them. In addition, it can make a person kind of lightheaded and cause dry mouth, constipation, flushing, headaches, and urinary issues. Now, I have very rarely used this, and not with great success. How about you?
Me neither. I tried it a couple times. It just had too many side effects.
Yeah.
I used Robenol for, again, kids with developmental delay who drool a lot, and that's what we grew up with.
Right.
But not for this. A newer approach I saw in a throwaway journal is using oxybutynin, also known as ditropan. We commonly use this to treat overactive bladders, can be used off-label for hyperhidrosis also. I've never used it, but there are a couple studies out there, and preliminarily they're very positive. But again, not use it. Have you?
No.
Ditropan?
No.
Then there's Botox. I have heard of this. Injections of Botox really work well, according to Dr. Treat, but this effective treatment requires 20 to 30 injections per site, and especially on the palms, it's really lots of nerves. It's painful.
Yeah.
I looked it up, and this type of treatment can cost $1,000 to $1,500 per session, and has to be repeated on average every 6 months in order to continue its effectiveness. Finally, there's spinal cord surgery. In this procedure, the nerves to the offending glands are severed. This can work, but it can also result in increased sweating in other places, and it's surgery, so it's a big deal.
But hold the presses. There is a new option out there. Topical glycopyrronium, which is called Qbrexza. Qbrexza was just approved this last year for hyperhidrosis for patients 9 and older. This medication comes as a wipe, which is applied to dry armpits after making sure there's no broken skin. One wipe, so one physical wipe, is good for the treatment of both armpits. This should not be used with occlusive dressings, as Rob said that sometimes others are. Once again, this is an anticholinergic and related to glycopyrrolate, so it has the same possible anticholinergic side effects, which include preventing sweating to the extent that it can be a risk for heat stroke, constipation, dry mouth, etc. Particular care must be taken that the medication doesn't go near the eyes, since if it were near the eyes, it can cause mydriasis or large pupils on the side that is touched. If both sides are touched. Just like the drops that the eye doctor uses to dilate the eyes for the exam.
And right before traveling to Florida for the meeting, I had my first patient come in who had been prescribed Qbrexza by his dermatologist. And he found it worked well, but he was a runner, and it made his whole body not sweat, and he didn't feel good. He stopped using it, which is good, because he could have gotten heat stroke. And because, again, not sweating can be dangerous. But we talked about the option of wiping it on much more lightly when he put it on his armpits, since the side effect is likely dose-related. And last I heard, this seems to be working better without the side effects. Dr. Treat mentioned that he's used it on patients with good success, but it's not approved for the palms. But obviously, that's where we think about using it, because that really is the most distressing part for many of these young people. I mean, he showed pictures. Some of the people have hyperhidrosis that literally in the middle of the day, their palms are dripping. And you can imagine how socially debilitating that can be, and often in the workplace, how debilitating that can be. He did talk about a patient who was on Qbrexza who touched his eye when the substance was still on his hand, even though Dr. Treat warned against this. And the teenager was quite uncomfortable with his pupil being really large and ended up going to the ER and ophthalmology. We all touch our eyes, and so that's a real risk of doing it. When I got back from the meeting, the third patient I saw the next morning was someone else who also had put on Qbrexza by another dermatologist, but he had also told me the same exact story. He touched his eye. He ended up going to ophthalmology. He had to wear an eye patch. But he was still happy that his palms were better, and now he's just much more careful about not touching his eye. So it's early, but I am excited about this new topical option for hyperhidrosis.
Yeah, this really seems to be quite a boon, I think. And the other thing that always has to be taken into account, especially when we're trying to negotiate things with how our prescribing is going to affect the patient's pocketbook, is this stuff's crazy expensive. I just, as Rob was talking, went on to GoodRx, always a nice place to find what you can get something for kind of on the cheaper side if you don't have the insurance coverage for it. And let me see here, one box. Cheapest around here, $552.
Now, my patient actually, it's one of those things, obviously the company wants to get this out. Right. So the dermatologist had him contact the company, and he ended up getting it for about $120. Not cheap,
right,
but much better than $500.
Yeah, and I always think like $120 for now, right? I mean, a little bit of that is, I think, not a bait and switch, but a little bit of reeling them back in.
Right, but these kids are desperate.
I hear you.
Yep.
Yeah. Okay, so our second dermatology topic from Dr. Treat was infantile hemangiomas. We also borrowed information on this topic from an excellent article on hemangiomas in this July's Contemporary Pediatrics, which quotes Dr. Sheila Friedlander, who's professor of dermatology and pediatrics at the University of California, San Diego School of Medicine, and a pediatric dermatologist who is a national expert on all things pediatric derm.
And I just to interject, if any of you out there treat kids and medically treat kids at all, you should get Contemporary Pediatrics every month. I loved it when I was a resident and early in my career. Then it got kind of sucky for a while.
Yeah, I remember that.
But now it's back, and it's really great.
Yeah, it is. It's a tremendous resource if you...
We have no relationship with them.
No, but it's a tremendous resource if you really aren't interested in like the esoterica of studies, and you really just want to get down to the brass tacks of this is what we do in the office.
But being evidence-based.
But thorough. Okay, first a little review. So hemangiomas are benign tumors of the vascular system, specifically of the endothelium of blood vessels, and they consist of small, closely packed blood vessels. They're commonly known as strawberry hemangiomas, but they're also called strawberry marks, nevus vascularis, capillary hemangiomas, hemangioma simplex. All these terms are really used in the same tone. And they may appear anywhere on the body, but most commonly are on the face, scalp, back, or chest. Hemangiomas are not typically present at birth, but generally appear within the first several days to months in an infant. The typical infantile hemangioma starts as a faint red patch, sometimes looks a little bit like a bruise, within the first few weeks of life, and can be seen up to 4% of babies. These lesions can have a rapid growth phase between 1 and 3 months, growing much faster than the baby's bodies are growing at that same time, and they will stop growing or slow down between 3 to 9 months of age on average, and start to involute or kind of like reverse on themselves and collapse by the time the infant is about a year old. About 90% will have completed this involution by the age of 5 to 9, but that doesn't mean that the skin will ever return to completely normal appearance.
Right, and to be clear, these hemangiomas are different from the much more common nevus simplex or flame nevus, also known as salmon patches or stork bites or angel kisses, that we see in 30 to 40% of all newborns. I think actually more when you look for it.
Yeah.
And which are rarely associated with any kinds of ongoing medical concerns. 99% of these type of skin findings will resolve, and the ones that don't, usually the ones in the back of the head just above the neck. The ones around the eyelids and forehead usually resolve quite nicely. One of the only times we have to think of something more serious with these type of vascular areas is when they are associated with a condition known as Beckwith-Wiedemann syndrome. Now, I have a child in my practice with this condition. These infants sometimes have the classic flat, pale, reddish purple facial lesions at birth, most commonly eyelids and forehead, but other findings, which are more specific, are macroglossia, macrocephaly, which again, big tongue, big head, asymmetric growth. These kids are at risk for developing certain types of cancers later on and have to be followed closely, often with blood tests and ultrasounds. Another distinctly different thing than hemangiomas, but a lesion that's sometimes confused with hemangiomas are known as port wine stains. These are more purplish, and the big risk is when it involves the forehead, upper eyelid, the cranial nerve V1 distribution, which is the top part of your face. In this case, we need to think of Sturge-Weber syndrome, which is associated with a 50% chance of seizures and neurologic issues and is always on the pediatric boards. Always on the pediatric boards. These children need a brain MRI to more clearly define their condition.
But getting back to those infantile hemangiomas, again, most growth with these lesions is within the first 3 to 4 months, and in the long run, they don't always completely involute. The key management point for these, according to the new 2019 guidelines, is that early referral should be made to a hemangioma specialist, ideally within the first 2 months, especially if involved with any anatomically high-risk areas. This is a big change from past recommendations, and pediatricians, family medicine docs, physician assistants, and nurse practitioners should be made aware of these new guidelines and should be thinking about referring these kids promptly. The reason for the semi-urgency here is that there are excellent treatment options available now, but they are time-sensitive.
Oral propranolol, given by pediatric dermatologists, has revolutionized the treatment of these hemangiomas, and early treatment with oral propranolol prevents a whole lot of serious problems later on, including also bad cosmetic outcomes for these babies. So we should be referring all infantile hemangiomas that are higher risk. The risk is mostly defined by location. As Dr. Treat and Phil Dunphy always say, location, location, location. Did you get that?
I did get that.
Okay,
one.
good.
Mm-hmm.
If you see hemangiomas in a beard-like distribution on the face, you should refer because of possible airway involvement. Dr. Treat mentioned that when you see kids with recurrent croup who keep getting steroids and getting better and then worse again, be aware of any hemangiomas like this and then think of airway hemangiomas. The steroids may actually shrink the hemangiomas temporarily and the child gets better, but it's a ticking time bomb because the hemangiomas regrow in the airway. So do you refer kids to ENT who have recurrent croup, Matt?
I will, if I'm that concerned, I'll usually get an upper airway fluoroscopy first, just to see if there's anything anomalous there, including either hemangioma, sometimes an HPV lesion, something along that lines. And that at least gives me some more information before I send them along to ENT.
You know, I used to do that a lot, but I've skipped that now because some radiation dose, and also they're so good even in the office of taking a quick look down there.
They have been doing a better job.
So I sometimes will go to having them see ENT looking, and you can miss it on indirectly.
Sure. Oh, for sure. So any hemangiomas at the nasal tip should be referred due to the high likelihood of permanent disfigurement with these. Hemangiomas around the eyes need to be considered for referral due to vision risk, and those of the lips due to the potential for bleeding issues and possible speech and eating problems. Those around the anus and at the vaginal area can be problematic from the standpoint of ulceration and bleeding. Also, hemangiomas on the face should be considered for referral, and plastic surgery may even need to get involved. Lastly, hemangiomas of the lumbosacral region need to be taken seriously. They can be a sign of underlying spinal cord anomalies. We have previously discussed obtaining an ultrasound of the lower spine for this, but Dr. Treat gave an example of a case in which the child had concerning-looking hemangioma over the lower spine and had a normal ultrasound, but still ended up having a spinal cord tethering that was only visible on MRI. So, does this mean we necessarily need to do an MRI on these children? No, but we should always keep our antenna out for these kind of phenomenon, even if the ultrasound's okay. Hemangiomas are also considered higher risk if they ulcerate. This type of history can lead to infection, scarring, and pain. Hemangiomas growing rapidly anywhere on the body are at higher risk for this type of behavior. Having said all that, it's a good time to quickly review the FACES acronym and syndrome.
Always a good time, Matt.
Yes. When is it not a good time to review this? That's PHACES, which stands for P, posterior fossa malformations, H, hemangiomas, especially large facial ones, A, arterial anomalies of the internal carotid, C, cardiac issues like coarctations, VSDs, and PDAs, E, eye abnormalities like cataracts or glaucoma, and S, sternal defects or a supraumbilical raphe. Also, specifically, we need to seriously consider referring any baby with 5 or more hemangiomas anywhere on their body, no matter how small the spots are, because this can be associated with a syndrome like diffuse neonatal hemangiomatosis, which is potentially life-threatening. This condition, with numerous cutaneous hemangiomas, can also be accompanied by visceral hemangiomas with large lesions in the liver, so a liver ultrasound is warranted. So, get these kids promptly evaluated either in person or via photographs within the first 2 months for changing birthmarks or those anatomically high-risk areas.
Yeah, I didn't know about that 5 or more.
No. I didn't either, because I've probably,
I've
probably had
they're
a
all in
couple.
benign places.
Sure.
One arm, one leg,
they're
watch
little.
it.
Yeah,
but
no.
I think I'll be
Makes
more
sense.
aggressive about
I had
that.
a kid once with a huge cavernous hemangioma in his liver, and it was undetected, and it was essentially eating his platelets. So he presented like with a problem with clotting.
Right.
Yeah, it was really crazy as an infant.
Right. So did that kid have a lot of hemangiomas?
No.
Right.
I think he just had a few. But
I think they used to call that Kassebeck merit when you had a big hemangioma,
Yes,
ate it up. Although I've heard dermatologists say that's overblown.
Yes.
That's not that
It's
common,
always
but
on the
obviously
boards, too.
Right, it's always on the boards, yes. So what really got my attention in the new guidelines is a recommendation for prescribing topical Timolol ophthalmic 0.5% gel forming solution for early therapy of hemangiomas that are thin or superficial. The dosing here is usually 1 drop applied to the hemangioma twice a day. This is obviously just for superficial hemangiomas and won't work for deeper hemangiomas. Now, I understand that this treatment is off-label, but I've had quite a few babies treated with this topical therapy at home prescribed by the pediatric dermatologist to avoid their hemangiomas from becoming larger and perhaps to avoid having residual disfigurement despite eventual involution of most of them. Now, have you had any of your patients being treated at home?
I have.
This?
Yeah, at home and successfully.
Right, and Dr. Friedlander, in that Contemporary Peds article, mentioned that topical Timolol solutions give much less general systemic exposure to a beta blocker than oral propranolol, and it's much more safer to use. She mentioned that topical Timolol essentially short-circuits the growth cycle of superficial hemangiomas, which can then lead to an abrupt arrest in their growth. But she specifically mentioned that pediatricians, in her opinion, can feel comfortable using the topical Timolol approach with, for example, a young baby with a small hemangioma where there's a cosmetic concern over the long term. For these young babies, we can have the parents start topical Timolol 1 drop twice a day within their first few months of life, and it can make a real difference in a very safe way.
Yeah, it's really quite a boon apparently, and I've not done it yet, but certainly it's not something that I would be opposed to doing. Just to reiterate, this is Timolol ophthalmic 0.5% gel forming solution that's used, so it is an ophthalmic drop. But apparently, this is the most convenient and easiest way that this is easy access for those of us prescribing. So if there are any issues that arise from this course of therapy, we can certainly then call the dermatologist. These children need to be followed up closely if we choose to treat them in this manner. So I can certainly imagine having a child with a solitary hemangioma on the arm or leg or forehead in a non-high-risk area, but which is beginning to grow quickly, and starting the topical Timolol quickly to avoid suboptimal, cosmetic outcomes for years later, even better than if it had naturally involuted. However, this type of treatment does need to be done with caution. Even though the treatment's topical, we still need to be aware of the fact that beta blockers have side effects and leave this approach to the dermatologist if the child has any pre-existing conditions, particularly those of the heart, lung, or eyes.
Absolutely. I'm not going to do this if there's any kind of issues like that. So, Maddie, I think we're going to call it. We got more for our next episode as we're kicking off season 3.
Always more. We're on a roll. Momentum. All right. Good night, Robs.
Good night, Moon. Podcast Pediatricians Productions. All rights reserved.